everyone, now let us discuss about drug therapy for migraine. So migraine is a headache that afflicts 10 to 20% of the population, and although migraine is a specific neurological syndrome, the manifestations may vary widely. And generally or principally there are two types of migraines, migraine without aura and migraine with aura. So, migraine without aura is also called as common migraine, whereas migraine with aura is called as classic migraine. Migraine with aura is again categorized into migraine with typical aura, migraine with prolonged aura, migraine aura without headache, migraine with acute onset aura. These are some of the subclassifications of migraine with aura. This is classic migraine, whereas migraine without aura is common migraine. The premonitory aura may begin as long as 24 hours before the onset of pain, and it is often accompanied by photophobia, hyperacusis, polyuria, diarrhea, disturbances of mood and appetite. These are the associated manifestation with the migraine. And the premonitory aura, it can begin before as long as 24 hours before the onset of pain. These symptoms may occur even 24 hours before the onset of pain. The accompanied symptoms are photophobia, hyperacusis, polyuria, diarrhea, and disturbances of mood and appetite. Now, coming to the efficacy of anti-migraine drugs. The efficacy depends upon whether it is varied by various factors such as absence or presence of aura, duration of the headache, and the intensity and severity of the headache or migraine. So these are some of the variable factors that can affect the efficacy of anti-migraine drugs. Absence or presence of aura, duration of headache, severity and intensity of the migraine. Coming to the pathogenesis, it can be categorized as vascular theory and neurogenic theory. According to vascular theory, migraine occurs due to initial vasoconstriction or shunting of blood through carotid arteriovenous anastomosis, and this produces cerebral ischemia and starts the attack. When it comes to neurogenic origin or neurogenic theory, depression of cortical electrical activity followed by vascular phenomena can lead to migraine, and the neurogenic inflammation of affected blood vessel wall also occurs. And this neurogenic inflammation of the affected blood vessel wall is amplified by retrograde transmission in the afferent nerves and release of 5-HT, release of inflammatory neurotransmitters such as 5-HT neurokinin substance P, nitric oxide, calcitonin, gene-related peptide, CGRP. These are some of the neurotransmitters or mediators that amplify the neurogenic inflammation of the affected blood vessel. And in case of migraine, pulsatile dilation of certain large cranial blood vessels is the immediate cause of pain. The immediate cause of pain is pulsatile dilation of certain large cranial vessels. And similarly, perivascular edema occurs due to leakage of plasma from the inflamed cranial vessels. Now, as we have discussed earlier, 5-HT release can amplify the attack of migraine. Based on that, 5-HT is a key mediator in the pathogenesis of migraine because platelet and plasma concentration of 5-HT varies with different phases of the migraine attack. If you conduct a study, the platelet and plasma concentrations of 5-HT vary with different phases of the migraine attack. Urinary concentrations of 5-HT and its metabolites are elevated during most of the migraine attacks, and migraine may be precipitated by agents that release 5-HT from intracellular storage sites. For that reason, the 5-HT receptor agonists have become the mainstay for acute treatment of migraine headaches. Coming to the classification of migraine based on severity. Based on severity, migraine can be mild, moderate and severe. When it comes to mild migraine, less than one attack per month will be seen, and pain will be throbbing, but tolerable headache lasts up to 8 hours. Here, whenever mild migraine is seen, patient is not incapacitated. Coming to moderate migraine, more than one attack per month can be seen. Throbbing headaches are more intense, last 6 to 24 hours. Nausea and vomiting and other features are also prominent. Here, whenever the patient is suffering from moderate migraine, the patient is functionally impaired. Coming to severe migraine, number of attacks will be 2 to 3 or more attacks per month. Severe throbbing headaches are seen which last 12 to 48 hours, often accompanied by vertigo, vomiting and other symptoms. Whenever the patient is suffering from severe migraine, patient is grossly incapacitated during the attack. Coming to the drug therapy based on the severity. For mild migraine, simple analgesics like paracetamol or aspirin can be taken. NSAIDs like ibuprofen, naproxen, diclofenac and mefenamic acid, indomethacin can be taken, or combination of simple analgesics and NSAIDs can be taken. All are effective in mild migraine. When it comes to moderate migraine, analgesic and NSAID combination do not afford adequate relief. Whenever the patient is suffering from moderate migraine, anti-migraine drugs have to be prescribed along with the antiemetic drugs. When it comes to severe migraine, a triptan or ergot alkaloid plus antiemetic along with NSAIDs can be given. And along with the triptan, naproxen is prescribed for prolonged migraine attacks. And for prophylaxis of severe migraine, propranolol and other beta blockers, amitriptyline and other tricyclic antidepressant, flunarizine and other calcium channel blockers, valproate and topiramate can be used. These are some of the drugs which are prescribed for prophylaxis of severe migraine, severe and moderate some cases. Now coming to ergot alkaloids. Coming to ergot alkaloids, they can be natural ergot alkaloids or semi-synthetic derivatives. Coming to natural ergot alkaloids, these are tetracyclic indole containing compounds which may be considered as derivatives of lysergic acid. They are divided into amide alcohol and amino acid alkaloid. Examples of amide alkaloid are ergotamine or ergonomine, which is oxytoxic. Examples of amino acid alkaloids are ergotamine, ergotoxin, which is nothing but mixture of ergocristin plus ergocorin plus ergocryptin. They are vasoconstrictor and have alpha-adrenergic blocking capacity. Other semisynthetic derivatives are dihydroergotamine DHE, dihydroergotoxin or codergocrine are anti-adrenergic and cerebroactive. Next is 2-bromo-alpha ergocryptine or simply bromocriptine is a dopaminergic agonist. Methyl sergite, it is mainly an anti-5-HT drug. Coming to pharmacokinetics, they have poor oral bioavailability, that is less than 1% due to slow and incomplete absorption as well as high first pass metabolism. The bioavailability is better after sublingual and rectal administration but still often erratic. They are metabolized in liver and excreted primarily in bile. Ergotamine is sequestered in tissues. This produces longer lasting actions compared to its plasma half-life of 2 hours. Ergot alkaloids, they effectively cross the blood-brain barrier. These are some of the pharmacokinetic aspects of ergot alkaloids. Coming to adverse effects, they are nausea, vomiting, abdominal pain, muscle cramps, weakness, paresthesia, vascular and other vascular spasm, chest pain. Coming to contraindications, ergot alkaloids are contraindicated in the presence of sepsis, ischemic heart disease, peripheral vascular disease, hypertension, pregnancy, kidney and liver disease. Coming to the first drug, ergotamine. It is most effective ergot alkaloid for migraine. It acts as partial agonist and antagonist at adrenergic and all subtypes of 5-HT1 and 5-HT2 receptors. Coming to mechanism of action, ergotamine acts by constricting the dilated cranial vessels or by specific constriction of carotid AV shunt channels. Ergotamine or dihydroergotamine, they reduce neurogenic inflammation, which is a characteristic of migraine. They reduce the neurogenic inflammation and leakage of plasma in duramater that occurs due to retrograde stimulation of perivascular afferent muscles. That is because, or this action is attributed due to partial agonism at 5-HT1D/1B in and around the cranial vessels. And sustained vasoconstriction because of very slow dissociation from the receptor, vasomotor central depression are also produced, and the actions of noradrenaline and 5-HT on smooth muscles are antagonized by ergotamine. It is a potent emetic through CTZ and vomiting center and moderately potent oxytocin. Coming to the route of administration, best route of administration is oral or sublingual. Parenteral route is hazardous. Coming to toxicity, at high doses CNS stimulation and paresthesis can occur, and on chronic exposure, which results in ergot poisoning, vasoconstriction is accompanied by damage to capillary endothelium, thrombosis, vascular stasis and gangrene. Coming to next drug, dihydroergotamine, DHE. Hydrogenation of ergotamine reduces the serotonergic and alpha-adrenergic agonist actions, but enhances the alpha receptor blocking property. DHE is less potent vasoconstrictor. It only leads to constriction of capacitance vessels, and it is a weak emetic and oxytoxic with some dopaminergic action. It is nearly as effective as ergotamine and preferred for parenteral administration because injected DHE is less hazardous. The next drug is dihydroergotoxin or codergocrine. They are more potent alpha blockers and a very weak vasoconstrictor. Dihydroergotoxin is more potent alpha blocker and a very weak vasoconstrictor. Partial agonistic and antagonistic actions on 5-HT receptors are seen. Enhancement of acetylcholine release in the cerebral cortex occurs due to dihydroergotoxin. Coming to the uses, dihydroergotoxin is used for the treatment of dementia. Next drug is bromocriptine. It is 2-bromo derivative of ergocriptine and it is relatively selective dopamine 2 agonist on pituitary lactotropes that inhibit prolactin release, in striatum, which has anti-Parkinsonian effect, and in CTZ, which has emetic effect, but less than ergotamine. In certain brain areas, they show bromocriptine shows weak dopaminergic action, and it has a weak anti-5-HT or alpha blocking actions, and it is not a oxytoxic. Bromocriptine is not oxytoxic. The next drug is ergometrine or ergonovine. It is a weak agonist and practically no antagonistic action on alpha-adrenergic receptors are seen. Partial agonist action on 5-HT2 receptor has been demonstrated in uterus, placental and umbilical blood vessels and in certain brain areas. It is moderately potent antagonist in GI smooth muscle and a weak dopaminergic agonist on pituitary lactotropes as well as CTZ. Emetic potential is low for ergometrine. Coming to the uses, it is used extensively in obstetrics to cause contraction of myometrine. Coming to the next class of drugs, they are selective 5-HT1D/1B agonists or simply triptans. Triptans are considered as the first line of drugs to patients who fail to respond to analgesics. The first drug in that class is sumatriptan. It is the first selective 5-HT1D/1B receptor agonist. Mechanism of action is it leads to constriction of dilated cranial blood vessels, especially the arteriovenous shunts in the carotid artery, which express 5-HT1D, 1B receptors. Inhibition of neurogenic inflammation of cranial vessels is also seen. In addition, it may inhibit inflammatory neuropeptide release around the affected vessel, as well as extravasation of plasma proteins across dural vessels. Coming to the pharmacokinetics, sumatriptan is absorbed rapidly and completely after subcutaneous injection. The oral bioavailability is only 15%. Absorption is faster after intranasal spray, but bioavailability remains almost the same. It is the only triptan available for nasal and parenteral administration as well. Sumatriptan is rapidly metabolized by MOA-A isoenzyme and its metabolites are excreted in the urine. Plasma T-half is 2 hours. Coming to the side effects, tingling in the head and chest, feeling of heat and other paresthesias in limbs, dizziness, weakness, bradycardia, coronary vasospasm, and risk of myocardial infarction and serious but infrequent adverse effects. Bradycardia, coronary vasospasm, and risk of MI. Few cases of sudden death has also been ascribed to sumatriptan. Seizures and hypersensitivity reactions occur, but they are rare. Coming to contraindications, sumatriptan is contraindicated in patients with ischemic heart disease, hypertension, epilepsy, hepatic or renal impairment during pregnancy, and sumatriptan and ergotamine should not be co-administered with each other within 24 hours. The next drug is rizatriptan. It is a congener of sumatriptan and is more potent, has higher oral bioavailability with slightly faster onset of action. The oral bioavailability of rizatriptan is 45%. Plasma T-half is 2 to 3 hours. Now coming to the drugs which are used for prophylaxis of migraine. The first class of drugs are beta blockers. In that, propranolol is the most commonly used drug. It reduces the frequency as well as severity of attacks in up to 70% of the patients. The starting dose is 40 mg twice a day, which may be increased up to 160 mg if required. The other non-selective, for example, timolol, and beta-1 selective, which is nothing but metoprolol and atenolol agents, are also effective anti-migraine drugs. So, propranolol, timolol, metoprolol, and atenolol are the most used as anti-migraine drugs. The next class is tricyclic antidepressants. In that, amitriptyline is effective in many patients but produces more side effects than propranolol. The anti-migraine effect is independent of antidepressant property, but this class of drugs are better suited for patients who also suffer from depression. The next class is calcium channel blockers. In that, verapamil was found to reduce migraine attacks but was judged inferior to propranolol. Next drug is flunarizine. It is relatively weak calcium channel blocker, but this also inhibits sodium channels. Frequency of attacks is often reduced by the use of flunarizine. It is claimed to be cerebroselective calcium channel blocker and may benefit migraine by reducing intracellular calcium overload due to brain hypoxia and other causes. Coming to the side effects of calcium channel blockers, sedation, constipation, dry mouth, hypotension, flushing, weight gain, and rarely extrapyramidal symptoms. Coming to the next class of drugs, they are anticonvulsants. Example is valproic acid and gabapentin have some prophylactic effect in migraine. The newer drug topiramate has been recently approved for migraine prophylaxis. Start with 25 mg once a day and gradually increase to 50 mg once a day or twice a day. They are indicated, that is anticonvulsants are indicated in patients refractory to other drugs or when propranolol is contraindicated. The next class of drugs is CGRP antagonist, a fully human monoclonal antibody, ergotamine, which blocks calcitonin gene-related peptide CGRP receptor, has been recently found to reduce number of migraine attacks when injected subcutaneously once a month in patients with severe migraine. It has now been approved by US FDA. Ergotamine is used for migraine. It is a fully human monoclonal antibody. Thank you for watching. Please subscribe for further videos on pharmacology and other related pharmaceutical sciences.